medication. So that was a big problem, so they took that on. Another thing they did was they allowed children to stay on their parents' insurance up through the age of 26, with a very popular position. And the last thing here that I'll note is the Affordable Care Act kind of set a path for the Medicare donut hole to be covered. Does anybody know what raise your hand if you've heard or know what the Medicare donut hole is? A couple folks? Okay, so very briefly, in the Medicare Part D program, which covers prescription drug benefits for seniors, there was sort of an extent up to which Medicare would cover, over the course of a year, those costs, and then that coverage would stop. And so, if a patient was paying up to $2,700, I think it was a year, Medicare would cover that, or cover it, in large part. And then after $2,700 a year, Medicare would no longer cover it to the same amount until the patient got to spending $7,000, then Medicare would pick up that coverage again. So that gap between $2,700 and $7,000, that was what they called the Medicare donut hole. So people who found themselves spending, in that kind of range between $2,500 and $7,000 a year on their medications, they were paying a lot of money out of pocket, and that was a big problem. Okay, things that weren't popular. Oh man, individual mandate. So part of the Affordable Care Act was requiring everyone in the United States to have health insurance, either through a private plan or through state-run exchanges. If you don't have health insurance, you get a fine. Turns out people don't like that. That's not a thing that people generally like. This was done just because of kind of the economics of expanding this insurance pool. Very top lines, if you're running an insurance company, you need to make sure you have enough healthy people paying into the system at one time so you can cover the people who are sick and needing resources from that larger pool. And so the whole kind of system is built on a balance of having enough healthy people paying in who are subsidizing care for the sick individuals. Does that make sense? Okay. Okay, not popular. Okay, the Independent Payment Advisory Board. Okay, raise your hands if you've heard the phrase Independent Payment Advisory Board. Like 1, 2, 3 people, right? Okay, now raise your hands if you've heard the phrase death panels used. Death panels, you've heard the thing? Okay, so that was sort of like a political communications thing. The Independent Payment Advisory Board was a Medicare savings option. So they put a provision in there that said if Medicare spending hit a certain level, the president could appoint a board that could make recommendations for cuts to the Medicare Part D program without any authorization from Congress. This it's not death panels, that was sort of hyperbole, but it would mean that an unelected board would be deciding which medications would be on, would not be on a Medicare reimbursement formula. So it would be limiting the brand medications that an individual patient could access when managing an illness. Does that make sense? So it's not death panels, it's like kind of Medicare spending, but anyway, okay, so that's what that was. A lot of business owners didn't like some of the new legislation in there around requiring them to provide insurance and at what level. And then so under the not popular column here, I also put insurance company involvement. Right now we've seen this kind of as an outgrowth of coverage options. As the market has moved forward, insurance companies can decide where they provide insurance, and in places where it's not viable for them, they sometimes will not provide insurance. So in a lot of rural counties, you might have access to a exchange to choose healthcare, but you might only have one provider to choose from, right? And it's kind of like, okay, well, what's the point here? But from the left, from kind of the more progressive perspective to here, a lot of people didn't want insurance companies to be involved at all. They wanted to have a public option. They wanted to get insurance companies out of the equation, just to have the government kind of be the insurance company. So I just put insurance company involvement up here because this is actually one that was not popular from kind of a different perspective from all these other ones. But yeah, I think it was important to highlight. So if you'll remember, so Obama comes in and he says, okay, we're doing healthcare reform. The first thing they do is they put together this big healthcare package. For a lot of reasons, they need 60 votes in the Senate to pass that healthcare package through, and they had exactly that many votes the Democrats did coming out of the 2008 election cycle. In 2009, Senator Ted Kennedy passed away very tragically, and Ted Kennedy was a big champion and healthcare advocate. But that meant for the Democratic caucus, they went down to 59 votes. They're actually short a vote. And so they had to get a lot of this done through compromise, frankly. A lot of people think of the Affordable Care Act as a kind of bastion of like liberal thought and progressive ideology. It's actually kind of a rough and tumble compromise piece of legislation, right? When the bill was first drafted, they had the public option in there. They had a Medicare expansion in there, lowering the age that you could get into Medicare on. But they ended up getting rid of a lot of that so they could pick up enough votes to just get the whole package through. So I just wanted to highlight that the Affordable Care Act in its final form was certainly a compromise between kind of liberal ideologies looking to expand insurance coverage for Americans and more conservative ideologies who were concerned about deficits and spending. So what we got was kind of a combination of the two things. Ultimately did a lot of good, but still to this day is, as we've seen, controversial in some ways. So we can go to the next slide if you don't mind. Thanks so much. Okay, so after President Trump was elected, as kind of a foil to President Obama, his first thing that he wanted to do was repeal or replace the Affordable Care Act in some capacity. And the Republican Majority Caucus took a lot of runs at doing this, and they couldn't come up with the vote threshold that they needed for this to pass. A lot of the things that were in our popular column, that last slide, require a 60 vote threshold. They got through on 60 votes initially, only just barely, but the Republicans really couldn't take a crack at any of that stuff unless they had that same number of votes to repeal some of those provisions. And they tried kind of different iterations of, healthcare, Affordable Care Act reform. They tried just flat out repealing the whole thing. But I think this is, this attempt to repeal healthcare legislation is actually a really good lesson in the power of advocacy, and what I hope you all do more of going forward, because as they were trying to take on, removing benefits from people, they were having sit-ins in their offices. The media coverage was, really caustic. I mean, I don't know if you remember this, but that was all anybody was talking about for the longest time. And there were protests, and there was, Twitter campaigns, and there was all kinds of stuff. And what it ended up meaning is that a lot of the votes they thought were sort of secure in these kind of swing states, so those senators started going, whoa, I have people, sitting down in my office and not leaving for days on at a time because they care about this issue. This maybe isn't something that we can just kind of do and get away with. There will be a political backlash, right? So anyway, that all is to say, at the end of the day, the only thing that really got done on kind of healthcare reform, the Affordable Care Act reform process, was when the Senate Congress passed the Tax Cuts and Jobs Act, which is the tax bill. It did include a repeal of that individual mandate. So if you don't have insurance, you no longer get a fine for not carrying insurance. That was kind of, at the end of the day, after all, literally a full year of taking the run of this, what they eventually got was the repeal of that individual mandate, because there's actually a lower vote threshold to do that than all the other stuff, but that's a whole nother conversation. But so that's kind of what happened. Cool. Okay, is that helpful generally? Okay, we're there. Okay, everything a little bit. Okay, we can go to the next slide. Great. Okay, great. Okay, so let's talk about research funding. Hooray! So Dr. Lew and many other wonderful researchers and physicians in Seattle work in institutions like Benaroya, like the Fred Hutch Cancer Research Center, University of Washington, Washington State University, Allen Brain Institute, Infectious Disease Research Institute, and a lot of these programs are funded very heavily through the National Institutes of Health, an organization that provides research dollars so they can do good work and come up with new cures. This always, NIH is a program that always has really good bipartisan support, no matter the rigmarole around what's going to be funded and what's not going to be funded. It seems like this program comes out pretty well. In fact, the average appropriation year over year since 2008 has increased by an average of $2 billion a year, in contrast to a lot of other programs that are getting cut. NIH program actually kind of increases, so that's pretty good. Per your advocacy efforts, thank you. This year that number will increase to even more, $3 billion, which is great and will help us get to a cure faster. So that's good news. Okay, let's keep going here. Okay, so Medicaid program. I think in the fallout around the efforts to repeal the Affordable Care Act, a lot of that was focused on limiting the number of people who can be provided basic healthcare services through Medicaid. I would say that the threats overall to Medicaid moving forward, I think, are much lower because the lesson has kind of been learned, frankly. You know, they took a run at healthcare repeal. They had this huge backlash from folks who, you know, now can have insurance or have healthcare coverage you didn't before. And, you know, I would say that overall Medicaid is probably in a less threatened state, like moving forward than it was, but there are still some policy ideas that have come up that would threaten this program that I wanted to highlight for you to kind of keep an eye out for. So one of those things is block granting. And what block granting means is the federal government would decide how much money a state can spend on healthcare through the Medicaid program and give them that pot of money and let them figure out how to spend it instead of them reimbursing for whatever the state says it needs. So they would say, okay, you know, instead of just accepting every claim in, they just say, okay, at the beginning of the year, you know, here's your chunk of money, you figure out how to spend this. And it would be up to the states, frankly, to do the unpopular part of cutting and taking services away from people. So that's one thing that's come up, block grant funding. There's some conversation, and this is more of on a state-by-state basis. You know, some legislators have put forward the idea of eligibility or proposed work requirements. So that would mean that in order for people to be eligible for Medicaid, they would have to, you know, reapply more often than they do already, or they have to submit, you know, some, you know, work verification. In some states, they even put out the idea that they have to, you know, Medicaid recipients have to go through drug testing and this kind of stuff. I think the top line here, the thing to keep in mind is that anytime you see something like, you know, eligibility or proposed work or et cetera, that just means more barriers for people and less access. So that's kind of shorthand for that. It'll be wrapped in like, you know, let's save money and do this. It's just, you know, less access. So a success story that I want to kind of highlight in this space was the reauthorization of the Children's Health Insurance Program. That happened recently again because advocates, you know, lobbied their members, you know, came to meet with them in person, held meetings, held roundtables. The Children's Health Insurance Program provides families who do not qualify for Medicaid. It allows them to provide health care insurance for their children if they're still low income. So there's a kind of a Medicaid eligibility level. If you're a family who's just over that Medicaid eligibility level, the CHIP program lets you provide health insurance to your kids anyway. So that was a big success recently. They got that reauthorized, the funding reauthorized for 10 years, which is awesome. Then I wanted to note here, this year we'll probably be seeing some form of a bill moving forward that would be providing a nutrition assistance program. So the Supplemental Nutrition Assistance Program, or SNAP, and the Women, Infant, and Children funds provide kind of wraparound nutritional support for Medicaid eligible populations. In a just kind of twist of committee fate, both of those programs are funded through the agriculture committees, and so there will be a food bill of some kind, an ag bill of some kind, and those programs will actually be in what is an agriculture bill, just because reasons, I don't know why, but that's how it goes. So that's something to kind of keep a lookout for this year. All right, let's go to the next slide. One more, okay. Great, okay, Medicare. And Medicare is the program that allows seniors and disabled persons to access basic healthcare services from hospitalization to prescription drug benefits. Some of the threats that you might see around Medicare going forward in an effort to save money, and we saw this with the Independent Payment Advisory Board that we talked about. A lot of times, legislators will put forward the idea of restricting the brands of medications that people can access through their Medicare Part D benefit. So that's something to kind of be aware of because every patient is different, right? And what an individual responds to when it comes to their personal health is should be between them and their doctor, and not some congressperson saying, well, this is a little too expensive. I think that one can just go off the list. So that's something we're always kind of watching for is Medicare Part D restrictions. So we don't want the government telling you which medicines you should have. I've heard this voucher system idea floated. This is actually somewhat similar to the block grant program, but it's for individuals. So the government would say at the beginning of the year, okay, Medicare patient, here's a set amount of money that you can spend on your healthcare this year. Go ahead and spend that money, instead of accepting claims as they come in. So that's another way they kind of look to save money. And then I've also heard House leadership this year floated the idea of raising the age of Medicare eligibility from 65 to 67. Another way to save money. So those are things to kind of look out for. We're kind of defense right now. So okay, let's go to the next slide. Great, advocacy 101. Okay, now I'm going to stop talking at you so much. I'm going to ask you some questions. And if you don't raise your hand, I'll call on you. So that's how it's going to go. My first question is, what is advocacy? When I say the word advocacy, what does that mean to you?
Advocacy is going out there and telling people, like Lupus advocacy. I do that with the team here.
Right.
We go to fairs and other events and tell people, hey, do you know what Lupus is?
Right.
This is how you can help. There's some channels to help you.
Absolutely.
Yeah.
And because you went to DC
Yes.
and did that, you had a very specific outcome, which was good. So that's great. Yes. So let's go ahead and do one click. That's a great answer. Advocacy is how we engage to create the outcomes that we want, right? And tell our story. In this context for a presentation here, I'm going to kind of frame this a little bit more in the how do we create policy outcomes space, but there are a lot of different ways you can do advocacy, right? And telling your story and getting out there and talking to people about what's going on is absolutely foundational to that. So, okay, great. All right, let's go to the next. Let's go click one more time. Okay, what is a policy outcome? All right, so I've talked through a couple of policy outcomes that have happened or haven't happened so far. Who wants to give me an example or can talk about what a policy outcome is, or how do we define that?
Funding for new
Yes.
drugs.
What's that?
Funding for new drugs.
Funding, yes, excellent. That is a policy outcome that we're often fighting for, is funding or not funding specific programs. What are some other examples of policy outcomes? Passing legislation, right? What language is or what language isn't in a particular piece of legislation. That whole thing around the Affordable Care Act, that was advocates coming